Okay, can you guys see that?
Yes.
Yes.
Okay. All right. So when it comes to like documenting things that you want to consider that you want to start off is obviously like reviewing your limits of confidentiality and documenting that you review your limits of confidentiality. If you're doing telehealth, or if you're not even offering telehealth, I would always encourage, I always encourage trainees or students to still provide the documentation for clients to sign for telehealth in the event that they cannot make it for in-person. You at least have that signed so then you're able to provide that service. So, talking to your patients about that. And then if you do, going over those telehealth pros and cons risks, making sure that if you are doing the telehealth portion, that you have their present address, the emergency numbers were provided, documenting that the patient agreed. So one of the things that I see a lot with documentation is that sometimes there's no follow-up in your statement that patient agreed to emergency plan in place, or patient provided X, Y, and Z. I'm sorry, therapist provided X, Y, and Z. Patient agreed they understood, right? So you need that statement because it just gives more credibility to what you're documenting. You also want to document that you ran over policies such as fees, appointment time, cancellation, so that way there's no misunderstandings around any of that. And that, your clients did provide you with written consent and verbal consent. Obviously, if they're showing up, they're talking to you, they're providing you with verbal consent. When it comes to minors, so one of the things that I tell like my trainees is that I will not allow them to see a minor without us reviewing the custody paperwork. They can definitely meet with the parent, right? And we can document that we met with the parent. We did the assessment with the parent. But if we don't review the custody, we're not going to move forward. And you want to document that you reviewed the custody paperwork, that you affirmed that there was, that you affirmed the whether it was sole legal custody, 50-50, and that you reviewed those signatures on the consenting paperwork. And then so that way that, everybody's on the same page, is documented. And also that you are, if it's a court-ordered client, that you reviewed goals of what they're being referred to you to do. And that the patient and you are on the same page regarding any of that. And that there's understanding around that. So that needs to be placed somewhere in the objective content, that you're documenting this, and that there was follow through from the client, how they responded. Any questions around this real quick? Okay. When it comes to documenting what your patient is stating, what your patient is sharing with you, you never want to give the impression that it's written in a subjective lens, like it's based on your interpretation, right? You always want to make sure that you're writing patient reported, patient stated, patient shared, patient described, because that's in terms of liability and everything. You want to make sure that we're describing it as the patient's words, right, to justify all of that. When it comes to the presenting problem, your presenting problem should already include clinical language around symptoms, stressors, anything that's going to justify already your diagnoses, that it's impacting them seeking services. Okay. And then later on in the Q&A, I can share an example. If a lot of you already are at Fresno Family, Jessica Bloom did a really nice job with providing you guys with a template, a sample client. And so that's what I'm going to review, because I just didn't want to reinvent the wheel when it's there. And so it's nicely done. Obviously, Jessica is a really good, documentation person. So it's a nice example. But the presenting problem should also include impairments, right? Like, so when these symptoms, when they're coming in with these symptoms, how does it affect their occupational functioning, social functioning, familial, and educational, right? So when I'm asking questions, when I'm meeting with patients and I ask them, thank you so much for coming. It sounds from the intake, X, Y, and Z are the reasons why you're coming. Is this still the reasons why you're coming? Kind of reinforcing that I'm reading the prior paperwork, that you're invested in what they already came in with. And they say, yes, I've been feeling this way, I lost my job. I'm having trouble with like getting a job. I've lost my house. I'm living from, place to place. I don't have stability. I'm just really struggling. I'm having a hard time. Okay. So when I'm asking these questions, then, you want to make sure that you're being culturally also sensitive to the way you're asking questions. Never assume that just because they're coming to services, they know what depression is, or what anxiety feels like, or what trauma feels like to them, what grief feels like, right? They just know that there's something's off, right? And so we never want to assume that everybody knows why they're coming, that they understand why they're coming in for in terms of symptoms, all right? So let me see here. What else do I have here? For example, when describing their stressors, I always like to say, how does this affect your day-to-day? Are you working? And even in my line of questioning, I'm already trying to figure out some of those parts of the biopsychosocial assessment, like work, schooling, family environment. I'm asking, how does it affect you? Do you know how does it affect you, right? Providing an example. So especially for me with because a lot of my clientele or patients are Spanish speaking, I have often need to describe or provide examples so they can kind of have a connection. And I might say like, sometimes when people are working, they might forget things or lose concentration. Does that happen to you? Or, sometimes when you're at home and you're trying to like cook food or, take care of your children, you might become very irritable or annoyed and maybe you lash out. Does that happen to you? Right. And so I'm already trying to explore those symptoms, but I'm also being mindful that sometimes people might not directly link that is part of like a mental health issue, right? Or and even just me right now, just not labeling all in all a mental health issue, because these are just normal responses to stressors, right? When we have an overwhelming situation happening to us, these stressors are going to affect us in some way. And so sometimes just being careful with not oh my god, what's the word, pathologizing a lot of this, right? Because it's just the normal responses, right? So, but just keeping in mind that at times you have to do this kind of explanation to explore and assess if this is what's going on for them. Let me see. The time frames as well is very important that you ask. How long have you been feeling this way? When did you start noticing that you were feeling this way? What do your family members notice? Did they tell you like, Mom, you're being snappy again, or Mom, you're always yelling, right? What do they say? And then what do they tell you? At work, do you notice yourself like shutting down, or with your spouse or your partner, do you notice yourself being more annoyed? Since like this stressor has been happening in your life, or because they have a history of trauma, and maybe obviously if they have a traumatic incident regarding sexual assault or abuse, and it hasn't been dealt with, how does that affect presently in the present with the relationships, right? In terms of trust and intimacy, and exploring that. I also like to ask for those somatic experiences, like, do they notice how their body responds when they experience certain symptoms? So, sometimes like I ask patients, if they're asking me about, if they're telling me about anger, like I'm just having a really hard time controlling my anger. Okay, well, how does that feel in your body? do you notice like your heart rate goes up? Have you ever like blacked out of anger, or see red? Do you ever lash out when you verbally assault others or physically? So also in this way, I'm also assessing impulse control behaviors, like their ability to regulate when it comes to if they're experiencing these like high intense feelings. Um, and so let me see. Additional things to consider is that your documentation should always include, especially during this first intake, is did you assess for suicidality, non-suicidal self-harm, homicidal, domestic violence if they're living within the same home, or intimate partner violence if they're living in different places, and psychosis. So some things that I like to ask is, it'd be if they're having like obviously a response to a stressor, I'll say, it's for some people, it's normal to feel like maybe they don't want to be here, or they feel very hopeless about life, or they feel like maybe they want to run away. Do those feelings ever come up for you? And they might say, oh, no, not at all. Um, or yes, I actually had this thought about like, driving my car off, or driving really fast in my car. Like they might describe to me like reckless behavior in some ways, but obviously I want to ensure that I'm assessing, right, for intent, plan, and means. In non-suicidal self-harm, I like to explain, sometimes people, when they're really overwhelmed or they're having difficulty like with their emotions, they might do things to their body to like release like some of that emotional release. Some people might self-harm by cutting, pinching, pulling hair. Some people might binge drink, or bingy. Like, does any of that happen for you? Or, in that regard. And so depending on that, then I will document. Obviously with homicidal, I will do the same. And then DV and IPV, if I sense that, obviously if they're are there victims or survivors, I like to ask, are you currently safe? And provide a safety plan and wellness plan in place. I would do the same with with suicide and non-suicidal self-harm or homicidality. Obviously assessing past and present, documenting that, and then I can provide you guys some examples too that Arch can send out of how I document. And then for well, what else do I want to say? Even if a patient reports that they had a history of suicide ideation, or maybe they had a past attempt or non-suicidal self-harm, it's important that you still want to provide an emergency instructions in the event that those um, uh, if those symptoms ever come back, or those stressors come back, that might intensify, their ideation in the future. It's important to do that because not only for, documentation reasons, but what if you open that day, they never thought about, obviously that maybe they've avoided their trauma or they've avoided their stressors, right? And they come to you and you open Pandora's box, right? And let's say that you didn't assess and you didn't provide them with any kind of like tools, right? And they leave and they end up doing something to themselves and they never come back, right? I always tell my students, like, from a legal perspective, like, if you get subpoenaed, right? Will your documentation say that, what would it say, and will it protect you? So not only are you doing it from patient care, right? Assessing and ensuring that, when they're coming to you, that you are providing, obviously assessing and providing tools or, emergency plans in place if that's needed, but also like protecting you liability wise, if it comes back, what is your note gonna say about what you did? If it's not there, it didn't happen, even if like, I've attended meetings with attorneys, and your note is the story of what happened, right? That's obviously clinically sound. But how is it also going to protect you? So not only what patient care did you provide, but how is it also, what did you do also as well? So all with that in mind, right? So any questions?
Miss Maira, may
Yes,
I ask a question or two?
sure, yeah. Or did you
Awesome.
want,
So,
I mean, Arch, did you want him to wait to later or you want, or,
No, it's totally fine. Yeah,
okay,
questions are welcome throughout. We'll just have a lot of time at the end for questions. But yeah, questions are definitely welcome whenever.
okay, go for it.
thank you, Arsh. I appreciate that. Miss Mata, two questions kind of came to my head. If it seems like they're maybe more in depth, we can definitely chat offline. But my first one, I was curious about, are there any kind of considerations we should keep in mind when doing an intake and doing notes when it's with a couple or a family versus an individual?
You do. So, for example, in your documentation, you want to make sure that you, if one is presents as the IP, right, and they're the ones that are disclosing stressors, asking their partner how do those stressors affect them as well, and documenting that you assess them both for symptomology and risk factors, right? Just because one person comes as the IP does not give you permission to like not assess the other person. You have to ensure that you have a good balance of like, okay, so if they're coming because of let's say relational conflict and then I think I saw Jessica in here. She's like the TV expert that she can chime in here, right? But if they're coming from relational conflict, and let's say that you're assessing for domestic violence and they denied, right? But I still want to ask, I want to ask and say, hey, and when there's these conflicts, does it ever get intense where maybe at times it affects you so much you feel like you rather not be here in this relationship, you rather take off, or you rather you know you feel like maybe like you self-sabotage and you're like, oh, I'd rather die than be without my partner, right? Because maybe divorce is on the table, I don't know, right? um I ask and explore if that ever comes up, right? Because I want to assess too, like, again, stressors can affect people differently and they can respond differently. So I want to ensure that when I'm asking them both, like, do you guys respond in this way? And you'd be surprised how many people have said, yeah, I have felt that way. Not that I'm gonna do it, but I think about like, I can't see myself without my partner. Like, I love them so much, and we have a family, we have children, or we have bank accounts, whatever. Like, I don't, sometimes I think about these things, right? And so I want to be able to provide interventions. So one, obviously they don't act on these thoughts, right? But second, how can we support the couple so that they can both provide that support and documenting that? So yes, so with family members, is that obviously if there's active domestic violence, you have to make a clinical judgment in there, appropriateness of assessment. Like at times I've assessed within the room, and then I separate them to ensure that I'm assessing appropriately each of them and providing the wellness plan and emergency plans for each, that depending if they're like if they're both doing the mutual if they're doing mutual abuse, or it's vice versa, obviously I provide them both with safety plans. But if I see that if one of them verbalizes they're the victim, the other is perpetrator, the perpetrator also requires a safety plan, like a timeout, fair fighting rules, an emergency plan. What can they do? How can you help them self-regulate and cope, right? So that they don't escalate to verbal or physical violence in that regard. But just in a nutshell, yeah, that's definitely, you want to have that documented in your intake. I don't know if that answers
Awesome.
your question, or if anybody else, any of the licensed peeps want to chime in too. Any other questions?
May I ask a small follow-up?
Yes, of course.
So I know as a, budding clinician, oftentimes I can feel a lot of pressure in that intake to sort of hit every point, right? This idea of like a perfect intake in my head often isn't the reality. I'm wondering if you could speak to that a little bit. And specifically, if there's any points like make sure if nothing else in the intake you hit this, or you make sure that like assess for risk, right? That's a must. Are there any other musts like that in that intake?
Well, yeah, because I know that right now as a trainee, you're not billing like insurance, and obviously you're not doing medical stuff, and my peers are gonna, attest to that. But honing down on some kind of, and it sucks, right? Because we're following this medical model where we have to diagnose, right? But honing in on a diagnosis to justify why they're coming in for services is probably like right up there with your risk factors. I'm sorry, assessing for risk factors. That would be my take on that. Yeah. But that's the ideal situation, right? Sometimes, I am obviously I'm giving you these pointers, right, to consider, not to say that first initial assessments don't go a different way, because depending, maybe you weren't able to get a lot of like historical information because maybe they came in already with a crisis and you're stabilizing the crisis, right? So I'm giving you these pointers just based on like in an ideal situation, right? And so I want to also be mindful that at times you're not going to be able to get or hit every checkbox because there's other things you have to stabilize during the session. But just being mindful of the things that you need to consider when you're going through the intake, as you get more practice through the years, you're going to be able to hone in to a manageable time frame that you're going to be able to hit most of these check boxes, right? So just being patient with yourself that you're learning. There's a learning curve to this. Assessments is what I do in my line of work. So obviously, like I've memorized. I tell my students, if you can memorize the major diagnoses you would be ruling out in a session, like generalized anxiety disorder, major depressive disorder, persistent PTSD, and adjustment disorder. And so that way you can, when you're entering your session, you already know what kind of line of questioning you will do to start ruling out some of those diagnoses. And so it comes with practice, it comes with time, right? But at least like knowing a lot of the terminology around the symptoms, so that way you know what to rule out when you're in there. Okay. Any other questions?